My name is Dr. Linda Neeson, and I serve as one of the Santa Fe Group members. Santa Fe Group is a consortium of health professionals from around the country dedicated to improving and identifying innovations in healthcare. Our recent meeting addressed improving oral health for older adults. You will see a series of interviews from many of our speakers who will address innovations and new models for improving the oral health of older adults. Teeth were designed to last a lifetime, and these are individuals who have new models for helping you do that. Thank you for joining us.
The elderly population is growing by significant margins and proportions, and there's clearly not enough people to take care of them, and there's not enough competency within the ranks of people who are already providers, either dentists, dental hygienists, or even medical providers to take care of this population. So it seems that the first thing we need to do is to make sure we have some strategy to incorporate geriatric education and clinical training right in the heart and the fabric of dental education.
If I could do one thing in order to catalyze change for better health care in the country, particularly focused on the elderly, I think I would choose to empower the elderly with a knowledge base that they need to object to the inadequacies of the current system. I would want them empowered to understand connections between oral health and systemic well-being. I would want them, with this empowerment, to become better lobbyists, more of a strong voice, if you will. And I think if we just did that one thing, and the elderly became active the way we know they can be, it would force the other changes to occur.
Earlier in the 30s, when Social Security was crafted, we're supposed to die at 65. And when Medicare was crafted in the 1960s, again, they used the number 65. But the fastest growing population in America are 80 and older. We're not prepared.
I guess we can think about geriatrics as a discipline and all the competencies associated with that. And one of the challenges is it's a very broad academic discipline. And so there's psychosocial dimensions, how to work with older patients and their particular psychosocial needs. There's a pharmacological dimension because we know that older adults use, because of their chronic conditions, often take a lot of medications. There's all the dental issues ranging from health promotion and prevention to restorative techniques. And so I think that's one of the big challenges in geriatric dentistry is that the competencies are so broad and you really need a very capable, competent individual to help others learn about geriatric dentistry.
Congress has come to understand the importance of oral health for children and has integrated the concept of oral health along with vision coverage in child coverage, but has not yet come to appreciate and fully understand the importance of oral health more generally.
Practicing professionals represent the largest pool of trainees that can help us get up to speed to provide better care for older adults as the surge of baby boomers moves through the system. I think that we are seeing that they are receptive, they're willing, interested in the information, want more hands-on, experiential types of opportunities. I think and another important take-home message is that they need clinically relevant, practical information that they can take back to their practices, and that it needs to be new. It can't be the same old stuff we've been teaching about in terms of treating older adults for many years.
Most baby boomers, in fact most people in this country that have dental insurance, have it available through a group-sponsored benefit, which means, for example, you'll come in, you'll get a new job, and in addition to a discussion about salary, you'll have a long discussion about benefits. Not so important to you when you're in 20s, but very important to you from the time you're 50 on, which is the AARP core membership. They have a group of members that range in age from 50 to whatever, as they refer to it. And so those particular individuals may, some of them be working, but people that are not working do not have access to group dental benefits.
The common denominator of good health care to me is integration and simplicity. take the simplest approach. It just doesn't make sense for mom's gums to be bleeding. Okay, that we do not need evidence-based to say this is not a sign of health. Bleeding anywhere else in the body would be catastrophic. In the mouth, we accept it. So we know that we have an inflammatory process going on. We have to treat that inflammatory process. If evidence-based shows that there are systemic links, that's wonderful. Right now, I want to treat the disease, and that's periodontal disease. And the correlation that could exist, even though it's not causal at this stage, between periodontal disease and respiratory, between periodontal disease and the exacerbation or uncontrol of diabetes in long-term care facilities. We want our dentists to be trained not only to work with hygiene, nursing staff, nurse practitioners, physician assistants, physicians, on integrating all of this healthcare. And what we mean by that is oral hygiene, nutrition, controlling bacteria. Last but not least, what we want is to do, a physician, a dentist, etc., should know that a hemoglobin A1C is the best monitor to control diabetes or even predict the diabetic. This is the change. We have to get away from glucometers, listen to what the American Diabetes Association is saying, get a 3-month readout by checking red blood cells, and come back with a method to maintain health, not to just treat disease.